And now I will talk to you about therapeutic application of keratopigmentation and the outcomes in 500 cases. The presentation was done in Dubai in the second color meeting in this, the last year, and it is exactly the experience that we have on these cases. Again, I have no commercial interest, and all these studies have been performed with grants from the Spanish government for innovation. And again, I start this presentation with one of the slides of my introduction. What can we do with these patients that after long life or just in young moment, they are disabled and they are suffering because this disability cannot be treated more than with cosmetic lenses that not always can be tolerated, and also providing a very important social and psychological impact. So this is the reason why we enter into this topic, and to offer an alternative to the more conventional ways, usually unsuccessful to long distance. So these patients have a variety of etiologies. They are affected by problems that have no non-solution, as I told you before, based on conventional treatments. Many times the surgery is mutilating, that is not acceptable, but not only that, mutilating surgery is not always successful. We know that there are ocular implants and following the visceration, and especially after enucleation, doesn't do a good job, and many times they are extruded or with problems, and also functional problems, as I mentioned to you formerly, have a different treatment, or many times have basically no treatment or no alternatives to do. So the first clinical study that was reported by us about this therapeutic application were performed in 40 eyes or 40 patients, in which we used micronized mineral pigments as a surgical alternative to improve the cosmetic appearance of these eyes. This was published in British Journal of Ophthalmology, and indeed was the first paper published in this topic worldwide. This is another study in which we published the capability of this technique to treat also functional defects of the iris, again in British Journal of Ophthalmology, and then we performed different studies in order to have the perspective and the medium and long-term outcomes of these cases. We had 500 eyes, or 430 patients, operated by us in between 2003 and 2024. We applied these two techniques. Both were described by us initially: superficial automatic keratopigmentation and superficial manual keratopigmentation. The superficial keratopigmentation has been used in those cases in which we don't have an adequate transparency of the superficial corneal layers. As a matter of fact, we are not able to perform properly with the intralamellar. This can be performed also as a second stage procedure in previously pigmented eyes, and so we have this option also even to repigment cases that were previously operated with lamellar techniques in order to cover and to change again the color of this eyes if the patient is not able to have this properly accepted, or we have any problem with the pigments. So this exclusion criteria that we follow in therapeutic keratopigmentation are those cases in which we have any type of ocular inflammation, especially on the ocular surface, when we have chronic epithelial defects and ulcers, when we have corneal delay in severe dry eye syndrome and extremely thin corneas. You should not perform this technique. We are penetrating the eye with superficial keratopigmentation, about 140 microns with the modern needles. The follow-up that I'm offering to you is from 6 months to 20 years. Definitely we have a very long post-op, and we have evaluated the outcome measures both by independent observer and by the patient. So we have two different proportions. The independent observer, who is not the surgeon obviously, qualify as excellent, good, or poor. The outcome of the patient cosmetically, and the patient satisfaction was checked individually as excellent, good, or poor, in order to know if we had agreement in terms of professional outcomes and agreement with the subjective outcomes observed by the patient. With this in mind, we have the application for purely cosmetic excluded from this study, and we are only offering to you data about therapeutic, either functional or mostly cosmetic keratopigmentation. This is the different groups that we had. As you see, most of the cases, or of the very important part of them, were because failed previous surgeries. These eyes were mostly blind, or even with this is bulbi. In these cases, obviously, the vision was totally absent. In other cases, we had corneal calcification and leucomas, but with marginal levels of vision. We had also blind eyes with transparent corneas, but with paralytic mydriasis and white cataract that were not adequate, or patients refused to have cataract surgery with no visual benefit, and in some cases in which we had absence of iris because of blunt trauma and other type of trauma that was causing cosmetic disability to the patients. In therapeutic functional procedures, the main part of the patients were those that were with aniridia, also patients that had albinism, obviously with photophobia, and progressive irisis was one of the cases where the iris was resected, leaving the patient with important glare, and this was included in this treatment as well. For pure cosmetic purposes, we had 3 patients that were not happy with the previous cosmetic keratopigmentation, and then we applied as a therapeutic procedure because the patients were psychologically affected as well. The main age was 45 years, but we have treated patients from 2 years of age, in case of micro-ophthalmos, to 83 years, so you can apply this technique in a very wide range of patients' age. And we combined in 2 or 3 procedures. That means that we had either squint surgery or oculoplastic surgery, a topic that will be covered by Dr. Alejandra Mesti immediately after my talk, in 136 cases. The most important was a squint correction. Many of these patients are exotropic and they need a correction that I do at the same time because I'm a squint surgeon as well. Glaucomas was the second, in which we applied the cyclodioid laser treatments at the moment of the keratopigmentation. In one case we did pupilloplasty, in the case with progressive iris atrophy, in order to eliminate the bridge of the iris that was just at the middle of the visual axis, and in some cases we performed as well ptosis surgeries assisted by the oculoplastic surgeon. This is very important because you can see here the agreement between the observer and the patient satisfaction. Observer evaluation, again, was an independent observer and the doctor, and was a professional ophthalmologist, was excellent, qualified in 69% of the cases, good in 29%, and poor in 1.53%. In other words, an independent observer, a professional, qualified as very good outcome, almost 90% of the cases. From the patient's perspective, was excellent in 70%, good in 27%, almost 28%, and poor in 1.53%. So you can be clear that this is not placebo. If the patients are happy, not because they become from being very bad and very cosmetically disabled, but because they are much better, and this is matching well with the independent observer qualification of the case, which is indeed great. If you ask to these patients, remember we are dealing with therapeutic indications, 98% told that they would repeat the treatment again, while 1.53 were considering that the result was not good enough to be performed again, and they were not satisfied. This is an important outcome, and you see how good is the matching between independent observer and the patient's observation. Let me show to you some cases in which we have, in this case, one patient with exotropia, and this brand eye, obviously, with this very bad aspect. This was the aspect that the patient saw 1 year after the keratopigmentation. This is one case that in the other eye had a green color, and this is how we reproduce the green color in this very disabled eye in pre-physical condition, having a very good outcome. In essential iris atrophy is a case that I showed to you before, is the one in which we cut this bridge that was at the visual axis, and we proceed with cosmetic keratopigmentation. This is very evident here, and how the cosmetic aspect was extremely successful, and you have to consider this patient with 24 years old was the subject of intraocular surgery, was for sure the compensated because the cell count was extremely low, as it happens in these cases as well. In cases of Resta-Valier syndrome, that might happen, especially following corneal graft surgery. We have faking intraocular lenses. We have these cases in which we have this indication is good. Then we have complications, and I want to show to you how some of the cases change the color with time. This is the problem that we have with some pigments that are not stable or were not stable at the moment that we saw. It's particularly noteworthy to see the C slide, in which we have part of the pigment going into green, while the part of this was in brown. The patient was even with dissatisfied. We were not at all, obviously. And you can see here down and right in the D how this brown color was turned into gray. So we had a problem with the pigments, sometimes because issues related to the photo influence of light, especially patients that live in countries with this intense light environment, and sometimes because simply talking the pigments are degradable and they can suffer redox reactions. There's a patient that had this is bulbi because a terrorist attack in Israel, and this was the aspect of the patient. After the surgery, the patient was extremely happy. This was following a traffic accident. You can look here that the patient, even that has some enophthalmos, the aspect is really good and the patient was extremely satisfied. This is a patient that had this white cataract in a totally blind eye and was not happy with having cataract surgery, and we did the keratopigmentation with the cosmetic aspect that you can see here as well. This patient had also a blind eye following different retinal procedures that finally ended in this result, which was remarkably good for the patient. Also, this patient that had this is bulbi because retinal detachment operated in several occasions, and that was with this aspect for 20 years, how he recovered cosmetic appearance almost completely normal, and it's difficult to know which is the disabled eye that was before treatment. There's another case that had a congenital coloboma with a very poor quality of vision. So this case developed. We respected the central part of the cornea at the beginning, but finally we covered also the central part, thinking that there was no way to restore useful vision in this eye, and the cosmetic appearance of the patient, again, as you see, is very good. Other case was following a traffic accident. The patient had a white cornea with glaucoma, and ptosis were restored thanks to the assistance of Dr. Amesti, the cosmetic appearance having this good cosmetic aspect from the enophthalmos, ptosis, and the cosmetic keratopigmentation. Other case in which we had following repeated glaucoma surgeries, a failed eye and blind that finally become endotropic, how this patient was after the squint surgery and the therapeutic keratopigmentation. Other case that was also the victim of a trauma and was denied because ethical, moral limitations. He was from religious origin, and you can see that this patient recovered a very adequate and very good cosmetic aspect following the surgery. Same happened with this patient that was with this disability. This patient had almost a blind eye, but was because of this anisocoria and this abnormal iris with permanent mydriasis, was very disabled, and following corneal squint surgery and corneal keratopigmentation in this case was recovered, same with this Ulrich-Tabalier syndrome. And finally, the clinical results, as you see here, were between therapeutic and functional. 73% almost of the cases were therapeutic. Functional cases have been popularity with us, and we are doing it more and more. Superficial techniques were applied in 47% of the cases. Of those of you that want to use this technique for therapeutic indications, you have to learn how to use the superficial technique, manual or femtosecond assisted keratopigmentation. Many times, if you have new vessels, you cannot use femtosecond laser, and you have to get the instruments to perform the lamellar tunnels, and these lamellar tunnels will perform manually in some cases, and in 60% of the cases, we use both manual and femtosecond assisted. This is a summary of what I told you before. Satisfaction survey was from the observer very high, and from the patient's evaluation very good as well. And there are the different papers that we have been published, that all of them are in PubMed. You can read all of them one by one, and definitely we have at this moment that therapeutic keratopigmentation, it should be considered as a new surgical approach for the correction of cosmetic and functional disability in these eyes. There's a good level of evidence and positive outcomes. Even at 20 years of follow-up, surgical techniques might be superficial, therapeutic, or mixed. And finally, long-term studies are still necessary to know the long-term cosmetic and anatomical evolution of these cases, mainly because of the pigments. The pigments are changing. Some of the pigments that we used in the past were better than the ones that we are using now. Definitely, we need to work on the pigments, and these pigments have to be performed specifically for the eyes, because dermatological pigments are not always good, because they induce thermoreactivity, and you can have new vessels in the cornea as well. So need pigments is the main issue now in this technique. We need the industry in this sector to develop pigments that have to be qualified for therapeutic application. They are not the same ones that we need for cosmetic purposes. They are denser, and this should be in the warranty that they don't have iron, because one of the problems is that they are quick time mandating. As I told you before, we have one of the module of our online course on refractive cornea cataract and intraocular lens surgery of our university with 20 ECTS credits and 3 hours of multimedia learning and offering this new type of cornea surgery. And I want to thank you again for your very kind attention. And this, remember that we have the Keratopigmentation Society, the Keratopigmentation Club, that now is in the beginning of the process. And I'm sure that those of you interested in this important topic will join this society, because in this society we have the umbrella to discuss, to promote, and to solve the limitations, complications, how to solve problems in this surgical thing. Thank you very much for your kind attention.